Thank you very much for asking me to share my views and on this complex subject. Now, I will start with some case presentations, and we will take it from there. I'll just illustrate how difficult the problem is with the posterior urethral valve. Now, this is a case of a term baby, a newborn, 3.5 kilos, normal creatinine. It was a stable baby. So a primary valve fulguration was performed. And as you can see here, you can see the dilatation in the posterior urethra, and that is a hypertrophied bladder neck. Now, this is the repeat VCUG after 4 months. There is some dilatation still there in the posterior urethra, but the anterior urethra stream has become better. Now you see a lot of bladder neck hypertrophy is persisting, but the bladder shape itself looks okay. Now, the reason I'm stressing all these things is when you assess these patients after treatment, you need to know how the bladder is behaving, whether the valve is gone, and how the upper tract is behaving. So this is the same patient after 2-year follow-up, and we have done a chexoscopy. There is no residual valve, but there is bilateral mild hydrouretronephrosis in this patient. The creatinine is still normal. There is no urinary tract infection, and there is no wetting. So the child is having normal voiding cycles. But if you can see here, behind the bladders, you can see the dilated ureters there. And there is a upper tract dilatation. So this is a patient where there is an early evidence of persistent hydrouretronephrosis after we have cleared the posterior urethral valve. Now that could turn into a late presentation later on. This is a 10-year-old boy who was seen in outpatients with the dribbling of urine and urinary tract infection, history of urgency and frequency. In the past, he had posterior urethral valve for which a bilateral ureterostomy was performed in the newborn period. He underwent a posterior urethral valve fulguration at 6 months of age, and the closure of ureterostomies were performed at 18 months of age elsewhere. Now, this is the patient I'm seeing for the first time. He's a 10-year-old already. He's dribbling of urine, and there is urgency frequency. So thus, bilateral ureterostomy increase the risk of the bad bladder. That is a question which we have to think about. Now, when we evaluated him, he had a persistent hydrouretronephrosis. And the first thing I need to do is to make sure that his urethra is okay. So we need to get a uroflow and VCUG. Being an older boy, we got a uroflow, and the uroflow showed a flat trace. And the VCUG showed evidence of narrowing at the posterior urethra. So we did a cystoscopy and did a OIU. And after that, he became all right. He had a good stream. His dribbling got better. But everything was for a short period, and then he presented again in another 2 years' time with urgency and dribbling, and this time the creatinine started going up. So we have to reevaluate him at this stage, and as we keep on stressing on this posterior urethral valve, it is not one problem where the treatment ends with valve fulguration. It actually starts there. So they can present in multiple ways. So this fellow had a urodynamics, and his pressures was going up to 35 to 40 degrees, 40 cc, and he started leaking at half the capacity or less than half the capacity. Now his ultrasound shows bilateral hydrouretronephrosis, and the right kidney has got literally no cortex with a 10% function and the poor drainage. Now, this is the background we have. Now, will you start him on oxybutynin at this stage? Will you start these patients on clean intermittent catheterization? Whether you administer him on nighttime drainage? So these are some of the questions and thought process which we need to go through. So as there is an urgency and dribbling, if the pressures are high, whether it is enough or whether we have already tried oxybutynin. So these are the things we need to really look at it. The anticholinergic medication are used as the main thing to relax the bladder by most of them. Some people use alpha blockers, to relax the hypertrophied sphincter, which is particularly useful when there is a large post-void residual volume. Clean intermittent catheterization and nighttime drainage have also been found to be a very useful settings in this situation. So that was his urodynamics, which showed kept on increasing the pressure with the unstable contractions as well as poor compliance. So he has been on anticholinergics and nighttime catheter drainage, and despite of that, he has been deteriorating renal function. Now that means two things: either the anticholinergic medication is not enough, we have to up the dose, or it's not working, the bladder is really bad, and then we need to go for an alternative method of management. So these are the patients where we sit on the edge, where we really have to make a decision. And as I told you earlier, this patient had a right kidney which was refluxing with a poor drainage and hydrourethronephrosis. So we thought, why don't we offer a lap nephrectomy and ureterocystoplasty? So this is what we have done. So we did a lap nephrectomy, and through the financial incision, that was the original ureterostomy scar. So we just extended the scar and then delivered the kidney through that, opened up the dilated system, and then did a bladder augmentation, a ureterocystoplasty. As you all know, ureterocystoplasty is probably the best option available in these patients who may be a potential candidate for transplant. And an ileocystoplasty has got its own disadvantages with the bacterial colonization, which may put the future transplant at risk. But at the same time, this is not always available. So whenever there is a patient with VURD, so valve unilateral reflux and dysplasia, there is a dilated system, I do not go for upfront nephrectomy in these patients, because I know at some point in the bladder starts behaving bad. At that time, I can do the nephrectomy and use the dilated upper tract as well as the ureters for ureterocystoplasty. Obviously, ureterocystoplasty doesn't provide a huge increase in capacity, but these patients are not a neurogenic kind of bladders. So a modest increase in capacity is probably enough, because their capacity is not always too bad. Now, this is a slightly different spectrum. So we are having a 16-year-old boy who presented for the first time with acute retention of urine. Although it should be happening at this age of development, it still happens. So this is he's been dribbling from childhood, and for some reason he has been missed, and the cystoscopy revealed a posturethral valve. So he underwent valve fulguration for the first time at the age of 16, and his damage has already happened. Hemoglobin is 6.5, creatinine is 9.8, his potassium is pretty high, and all the parameters show that he is already in end stage. So that is the huge capacity bladder, which is like a pregnant uterus. So that kind of decompensated bladder, even after valve fulguration, now he is not able to produce a proper flow. So that is a typically interrupted flow where he has to void with abdominal straining. So that is a Valsalva. So large capacity bladder typically voids with abdominal straining with a poor P-dead during the voiding. So these are the late presentations where we have to make some mechanism to make sure that these fellows are able to empty the bladder. Although the obstruction is relieved, you have left it too late. So what are the options prior to transplant? Does he go on a urethral CSC? Some of them may have a sensate urethra, and we may have to do a Mitrofanov procedure for them. Now, coming to the actual valve bladder, the term valve bladder covers all the dysfunctional bladders in patients with the posterior urethral valve. The term valve bladder syndrome was first used by Mitchell. Describes the pathophysiology where the underlying obstruction initiates cyclical events leading eventually to bladder decompensation. So if you go through this particular flow chart, the posterior urethral valve leads to littoral hypertrophy, and then there's an increase in intravesical pressures. The pressures getting transmitted to the upper tract causes impaired renal function, impaired concentrating ability. So you have an increased urine output. So already the bladders are small and there is an increased output. So what happens is it causes an impairment in the bladder emptying. So as the bladder is not able to store, the bladder is not able to empty properly, it keeps on filling, and then that becomes a vicious cycle, causing more and more problem. So they go through these phases. Initial period of bladder instability is there, followed by impaired compliance, and then they have poor bladder emptying, and then they end up in the myogenic failure. So the myogenic failure is the last stage where the bladder decompensates, it doesn't contract, and one is dependent on SCAC. So how do these patients present? In a young child, like 3 or 4 year old, the first time you have to suspect this is like when the child starts developing a daytime wetting. So a child who has been very well after valve fulguration, has been stable, and suddenly start having wet pants during the day. So that is one of the important way they present. Then raising creatinine or raising hydroerythronephrosis during the follow-up, that is another way they can be picked up. Despite the valve is gone, they start having misbehaving, the upper tract start behaving. The ultrasound is an important investigation to look for post-void residual volume, and often they have a large post-void residual volume, which may be because of a bladder neck component. Then uroflow is a useful investigation, particularly if the child is older than 5 years. Then voiding cystourethrogram can really help to eliminate the residual valves or strictures, and that should be ruled out before you even start any bladder medications. A neurodynamic study is a crucial step in deciding where exactly we stand, what stage of valve bladder this patient is in, and how to treat further. So that is the way to evaluate these patients. So if somebody is having a poor flow, that can be because of a stricture where the flow is very flat, or it can be because of a poor bladder contractility. So that can be a typical interrupted voiding with Valsalva voiding, where abdominal straining is causing the emptying. Now here in urodynamics, you can either have a poorly compliant with the high pressures, or you can have an atonic bladder where the voiding phase is having very poor bladder contractions. So both are important. You can see in this patient, in this urodynamics on the left, the flow actually is good. So there is no obstruction, but it is the bladder component which is causing a problem. And in this, the second urodynamics, it's actually the bladder emptying is the problem. There is no problem during the filling. So we need to know exactly where we stand. So if there is an early stage of valve bladder, so we can put them on anticholinergic medications. Some people put them on empirical anticholinergic medications straight away after valve fulguration. So they put them on oxybutyn at different doses. I don't. I generally wait to see how they are doing. Some of them do well. In that case, I don't have to give them anticholinergics. The problem with anticholinergics is how long you keep them, when to stop them. If you keep on keeping them on anticholinergics for too long, that itself may lead to an amount of you're precipitating an amount of atonic bladder. Then alpha blockers. Some people put these children regularly on alpha blockers. I don't. I prefer to use alpha blockers when there is a bladder neck hypertrophy and there is a large post-void residual volume. So those are the typical indications for alpha blockers. Mirabegrons, these have been used. Very little experience is there. We are actually doing a study at the moment to look at the role of mirabegron. We probably will be presenting our results in the UCCon. So again, all these medicines, how long to keep them, when to stop them, what is the maximum dose. So these are all done based on a trial and error method only. There is no right and wrong here, when to start, whether you start empirically before the event actually happens. But basic things are important. Timed voiding, double voiding. I mean, these are components of the urotherapy where they actually sit with the patient and the parent and tell that it is important not to keep a lot of residual volume. So because of the bladder neck component, they may not empty it completely. So a double void or triple void is sometimes essential to start fresh filling cycle there. Also timed voiding, some of them do delay the voiding, leading to too large bladder fillings. So that also should be avoided. So these are all simple methods. The role of interventions, bladder neck incisions. Some people do fancy bladder neck incisions. I don't fancy bladder neck incisions regularly. The role of Botox is unclear in valve bladders. There are studies where they have tried it. Mitrofanov can be useful, particularly if you want somebody to start the CAC program. Unlike the patients who are having a neurogenic bladder with a urethra which is not sensate, these valve bladders have a typically sensate urethra, and the hypertrophied bladder neck makes the catheterization sometimes difficult. It can bounce back and then cause severe pain, spasm, especially if it coils in the posterior urethra. So a Mitrofanov alone without an augment can be a useful option to enable urethral CAC in these patients. Now bladder augmentation, as I said, if at all possible, I will try to get the augmentation done with the ureterocystoplasty, but sometimes we may have to do a bowel augment as well in these patients, and a timely augment can actually delay or postpone the transplantation. Now, whether the augmentation should be done before or after the transplant, these are all difficult questions. The transplant surgeons sometimes do not want the augmentation to be done before. And there are a few reports where the transplant has actually reversed the valve bladder. So this catch-22 situation continues throughout. Now the syndrome of nocturnal over-distension of the bladder is real. In the valve bladder, nighttime drainage is really helpful to empty the bladder. And as urethral CAC, if it is difficult, for a Mitrofanov, you can also use the URITEP. So that is a ureteric Mitrofanov where a transureterostomy has been done and the distal end of the ureter has been used as Mitrofanov. You can also remove a non-functioning dysplastic kidney on one side and then keep the ureter as the ureteric Mitrofanov. So that is also possible. That's particularly if the ureter is not dilated, the upper tract is not dilated, then you're not going to use it for ureterocystoplasty. You might as well use it as a ureteric Mitrofanov. So I'll summarize here whatever we have discussed. So the important thing in the evaluation of a valve bladder is to exclude a structure or a residual valve before you even start any treatment. Anticholinergics, alpha blockers. These are all key interventions to be done at the right time. Timed voiding, double voiding. So these are all important part of urotherapy. Then CAC and nighttime drainage. It can be urethral CAC or via Mitrofanov. Both are useful. And a timely urodynamics, Mitrofanov and or an augment can be useful to delay the end-stage renal failure and a transplant in these patients with the valve bladder. Obviously, a nephrologist input is essential throughout. So we need to really assess which stage of the valve bladder we are in, and then titrate the treatment accordingly. So that's about it. Thank you very much.